Hey everyone, welcome in. If you are a medical coder, biller, or audit professional, you are in the exact right spot. I'm Harshal Tilak, and today we're kicking off part 1 of our massive 15-part masterclass series, Shoulder Arthroscopy and CPT Coding Mastery. If you've ever stared at a super complex operative report for a shoulder surgery and felt a little lost in all the anatomical jargon, don't worry. In this explainer, we're going to translate all that dense clinical language into a crystal clear visual framework.
Here is the quick syllabus for today's explainer. We'll start with our masterclass overview, cover the 3 key bones and the 4 shoulder joints, look at the clinical impacts of the anatomy, do a quick coder's knowledge check, and then finish up with a recap and a look at what's next. All right, Part 1, Masterclass Overview, Coding Foundations. So, why are we starting at the absolute very beginning with basic bone anatomy? Well, you know as well as I do that to confidently assign those complex arthroscopy CPT codes, yeah, I'm talking specifically about that tricky 29805 through 29828 range, you literally have to be able to visualize the skeletal landscape exactly the way the orthopedic surgeon sees it through their scope. When a surgeon documents a subacromial decompression or a labral repair, they aren't just giving you a code to punch in. They're describing a journey through a highly specific anatomical space. If you can't see that space in your mind, you're really going to struggle to code it accurately. Our goal in this series is to turn you from someone who just matches words in a book into an expert who truly visualizes and understands the entire procedure.
Moving right along to Part 2, the 3 key bones, shoulder framework.
Let's just strip away all the muscles, the tendons, and the ligaments for a second, and look at the raw, foundational framework of the shoulder girdle. The shoulder complex is essentially made up of 3 primary bones that intersect. First up, we have the humerus, which is the long bone of your upper arm. For our coding purposes, we're highly focused on the proximal articular surface, which is known as the humeral head. Next is the scapula, or your shoulder blade, and this one houses a critical, shallow depression called the glenoid cavity, along with the acromion and coracoid processes. And finally, bridging the front of the body, is the clavicle, or collarbone. Pretty much every single shoulder procedure you're ever going to code involves 1, 2, or all 3 of these specific bones.
Okay, into Part 3, the 4 shoulder joints, articulations.
Now, where these 3 specific bones actually meet is what creates the complex articulations you are constantly seeing mentioned in operative reports. The absolute star of the show in shoulder arthroscopy? The glenohumeral joint. It's actually fascinating how this works. It is a synovial ball and socket joint, but unlike your hip, the socket here is incredibly shallow. Basically, the body sacrifices deep structural stability for a massive, highly mobile range of motion. Because of this specific joint, the arm can do it all. Flexion, extension, abduction, adduction, internal and external rotation, you name it. It's an engineering marvel. But as we'll see in just a second, all that mobility comes at a pretty high clinical cost.
But hey, it's not just one joint. When we talk about the shoulder, we're actually talking about 4 distinct joints all working in harmony. Beyond the glenohumeral joint, we've got the acromioclavicular, or AC joint. That's where the acromion of the scapula meets the clavicle. As coders, you see this area targeted constantly for arthritis treatments or decompression procedures. Then, there's the sternoclavicular joint, connecting the collarbone right to the sternum. And finally, the scapulothoracic joint, which lets the shoulder blade glide smoothly against the rib cage. Nailing down these 4 distinct zones is absolutely vital for accurate procedural coding.
Part 4, Clinical Impacts, Anatomy in Practice.
So what does this all mean for us? The crucial takeaway for audit pros and coders is understanding exactly how this specific bone setup directly causes the pathologies we're coding every single day. This is the ultimate trade-off in human anatomy. Because the shoulder is built for extreme multidirectional mobility, rather than being deeply locked into a bony socket, it relies heavily on soft tissues to stay put, and that makes it super susceptible to mechanical failures. Things like subacromial impingement, labral tears, chronic instability, and acute dislocations, they are all a direct result of this shallow, highly mobile design.
Let's look at a really common example you'll find in patient charts, the shoulder dislocation. When a patient's arm is positioned in excessive abduction and external rotation, the inferior glenohumeral complex is acting as the primary restraint. But because there's a severe lack of ligamentous support and dynamic stabilization in that specific position, the joint is just highly vulnerable. Thanks to that anatomical weakness, anterior dislocation, which is where the humeral head pops forward right out of the socket, is by far the most common type of dislocation you're going to encounter in code.
All right, Part 5, Coder's Knowledge Check. Test your recall.
Let's pause for a quick active recall check. We do this all the time in our live CEU seminars because it really builds your clinical confidence and locks the info in. Here's your question. Think back to the skeletal framework we were just talking about. Which specific bone articulates with the glenoid cavity of the scapula? And critically, what percentage of contact does it actually make with that surface? Take a quick second to lock in your answer.
Okay, got it. The answer is the proximal head of the humerus. And here is the truly fascinating part. That humeral head only makes about 25% surface contact with the shallow glenoid cavity. Think about that for a second. Literally, only a quarter of the ball is actually touching the socket at any given time. This one simple anatomical metric perfectly explains why the joint is inherently so unstable and exactly why surgeons spend so much time in the OR just repairing the soft tissues, trying to hold it all together.
Part 6. Recap and what's next. Looking ahead.
Let's bring all these foundational pieces together before we wrap up today's explainer. We've successfully mapped out the skeletal framework. You now know the 3 key bones, the humerus, the scapula, and the clavicle, and how they form the 4 distinct shoulder joints. You've got a great grasp on the unique, highly mobile, yet shallow mechanics of the glenohumeral joint, and how that crazy 25% contact ratio leads directly to the instability and dislocations you code. Next time, in Part 2, we're going to layer on the soft tissue. We'll be mastering the sits rotator cuff muscles, the supraspinatus, infraspinatus, teres minor, and subscapularis, that originate right on the scapula and fight every day to keep this precarious joint completely intact.
So ask yourself this. How much easier is it going to be to code a complex Bankart lesion or a slop repair now that you can perfectly visualize the precarious shallow cavity involved? When you know the anatomy, the coding follows naturally. But it's those soft tissues we cover next time that truly hold it all together. Decode Healthcare with Harshal.